Started the class. Good morning, everyone, and welcome to our eLotus webinar today. Thank you for joining us. I'm Donna Chow, your host and your moderator for today's event. Today's webinar is being presented by Lotus Institute of Integrative Medicine. We are more popularly known as eLotus and have been holding educational courses for over 20 years. We are proud to be your trusted source for premium CEU content. So things have progressed a lot lately in the past month. Just want to know how you guys are doing at home. I just see half people are being really productive and the other half are really doing a lot of self-care and taking this time to just chill out before having to get back to close to how things were. I don't think things will ever be normal, and there are pros to cons to that. Yeah, so let me know how you're doing. Go ahead and type into the chat room. I can see it right in front of me right now. All right, so we'll be doing our webinars a little differently than usual. Here at eLotus, we want you to know that safety is our top priority during this coronavirus pandemic. We have taken preventative measures for keeping our speakers, our attendees, and staff as safe as possible. And to that end, this is why we've asked Douglas to present this weekend's webinar remotely from his home, and me as well. And this is our second time hosting our webinars remotely, so we want to thank all of you in advance for your patience and understanding as we navigate through our new reality. Please know that if you are here to earn CEUs and if there is any kind of dropout in the connection either on our end or our speaker's end, your CEUs will not be affected. If you have a dropout on your own because of your internet connection, just go ahead and log back in. It's not going to be a big deal, and again, your CEUs won't be affected, so you don't need to worry about that. So again, thank you for joining us today from all over the world. It's great that although some of us might be on lockdown, we can still have this cyber social gathering. I hope you guys are really excited for today's class. If you didn't attend Douglas's 1-hour webinar weekday back on April 8, you are in for a treat. If this is your first class with Douglas, go ahead and type first in the chat room. That way he has an idea of who his audience is. Wow, great. We have a lot of new friends joining us today. So today's class is TCM treatments for brain injury and concussion with Douglas Wingate, and this webinar is being recorded. Before we begin, I would like to cover a few housekeeping topics, and we are scheduled to end at 6 p.m. Pacific time today. Lunch is 1 to 2 p.m., and we'll have 2 breaks in the morning and 2 in the afternoon. So now let me give you an overview of our webinar room and what you're seeing in front of you. To the right of the video feed, you'll find the PowerPoint for today's class. A copy of these slides can be found in a PDF version from the course access page, and you can pick whether you want 6 slides to a page or 2 slides. Under the video feed, you'll find the video chat, and here you are welcome to connect with your colleagues who are also attending today's webinar live. For any side chatter, we ask that you private chat, and you can do this by clicking on the menu icon at the top right-hand corner of the chat room. This menu icon looks like a bunch of horizontal lines with an upside-down triangle. If you have any questions regarding your account or technical issues, we ask that you please start a private chat with the host. If you have any questions for our speaker, you can type it directly into the chat room. You'll be able to see it when presenting. And please do keep your questions related to the topic he is currently presenting. And if you have any technical issues, like someone I just saw wrote that they have a freeze. I don't see a freeze on my end. Are everyone else okay? So usually when this happens, it's due to the individual's internet connection. Typically, they're on a wireless connection, which we recommend connecting to the internet directly using an Ethernet cord for the best internet juice from your internet provider. All right, so just a quick reminder that you will be receiving CEU credit, and you can rewatch today's content as many times as you like for a whole month. And this class is packed with a lot of great information, so to fully absorb everything, it's always a good idea to rewatch the important parts, and you can do it again as many times as you like. And for our Gold Pass members attending today, you'll also have a full month's access access and complete your quiz, and you get access to the video recording for as long as you're a Gold Pass member, plus unlimited access to all of our over 3,000 hours of videos, which includes today's live webinars like today's class. And Gold Pass member can access any of our English courses for as long as you are a member. And speaking of sponsors, I'd like to thank Evergreen Herbs as well as their customers. Because of you, we are able to hold special promotional events. And so if you haven't already, please sign up for our email list. That's how we can reach out to you guys and let you know about promotional events, either sponsored by Evergreen Herbs. And so when you choose Evergreen Herb as your herb provider, then you're choosing to invest in the advancement of TCM as well. So I'd like to thank you guys for your support. All right, so let's get started with today's class. Okay. So if you have any technical issues, please write it to the host. And again, if you're freezing over and over again, it's due to your individual connection, unless you'll know that it's from the host end when everybody's feed is frozen. So we're good here still, and so just private chat with us to the host. That way we can keep the chat open for everyone, and that way we can keep the chat related to the topic only. All right, let's get started then. Today's class is on TCM treatments for brain injury and concussion with Douglas Wingate. And Douglas earned his Master's of Acupuncture and Oriental Medicine degree from the Oregon College of Oriental Medicine 2011. He maintains a private practice in Oregon and works as an adjunct professor performing acupuncture in the neurology department of the Oregon Health and Science University. Douglas specializes in the treatment of concussion and brain injury and is involved in research through the Oregon Health and Science University in training protocols and peripheral and polyneuropathies. He has volunteered with and served on the board of multiple nonprofits in Portland, serving veterans and individuals living with effects of brain injury. So let's get started with today's class. I'm going to pass the mic to Douglas, and if you can do one quick last testing before we begin.
All right, thank you, Donna. Just want to check volumes levels real quick, make sure everybody can hear me okay.
Yeah, sounds good.
Coming through all right? All right. Okay, shall we go ahead and get right into it then? Okay, so thank you very much to eLotus for having me, Donna, for that introduction and everything. A lot of people learning from me for the first time here, so that's excellent. I want to thank everybody for coming, taking the time out of your weekend to immerse yourself in this. It will be a lot of information, so a lot of slides, so it's great that you guys will have access to this for the next month. This will be a little bit different setup for me too. I've never done a presentation this long in just a setting on my own, so feel free to throw questions down in the chat box. I'm happy to try to get to those as we can. Like Donna said, we'll get a couple breaks in about every hour and a half with a lunch about 2 o'clock or 1 o'clock, excuse me, 1 o'clock to 2 o'clock. So today we're going to be going through and jumping into treatments for brain injury and concussion. If you had a chance to join my webinar last week as kind of a 1 hour introduction, we'll go over the base material in that and really elaborate on it. So the first half of the day will be mostly theory, so understanding how Chinese medicine looks at brain injury, how Western medicine looks at brain injury, a fair amount of neuroanatomy and neuropathology, so we can really understand what's going on when we're seeing patients who have sustained this kind of injury. And by understanding how that impacts them, we can then better inform our treatment strategies. So we'll go ahead and get started here. I saw one question about whether or not we're going to cover sleep disorders today. And we're not going to get too much into specific disorders or specific symptoms, so much as general treatment that can then be custom tailored to the more prominent symptoms. So sleep issues is definitely a big issue for a lot of people, but we're not going to get into the specifics of that. Usually if I do teach on this topic, it'll be a full weekend thing where one day is kind of what we're covering today, the second day is specific symptomology that a lot of people experience, but we will touch on what those symptoms are, and then based on the base material of treating brain injury, you can customize your treatment as needed to approach what's more prominent. So usually I'd ask how many people have any experience treating traumatic brain injury or concussion care. I got into focusing on this and treating a lot of it because as I was graduating from acupuncture school, I realized that it wasn't something that was really covered. I got an opportunity to talk with a neurooptometrist here in Portland, Oregon, who specializes and treats a lot of individuals with concussion and traumatic brain injury, and saw just how significant both the patients' lives were changed by their incident, and how much simply a proper saw that there was a real need for this to be addressed, and that Chinese medicine had a lot to offer when you took a look at it. And we'll get kind of into why that is. But so from there, I just kind of taken some time to try to understand that. It was recommended to me to participate and get involved in some of the nonprofit organizations that are support groups here in the Portland area for people who have a brain injury. And there I got firsthand hearing from individuals who were going through this experience, what their care, what their distract a little bit, but we'll get into all of that as far as specifics of patient care. Looks like there was a little bit of a freeze there. Hopefully we are good to go. I'm going to go ahead and get started with the material. Fine now, okay. So let's go ahead and talk about some of the general terminology that, if you're going to have a discussion about traumatic brain injury or concussion, is very important to be aware of, and just to be able to communicate these things. Or if you have a patient coming in and they tell you that this is what they've experienced, so you know exactly what that is. So some of the base terms that you may run into, the first one is ABI, which is an acquired brain injury. So this is a broad blanket term that's used for any sort of injury to the brain that was not what's not a congenital condition. Whatever happened within one's life, they had an incident that caused some sort of brain injury. So that's a blanket statement of anything that's not congenital. A subsection of that is what's known as TBI, or traumatic brain injury, and that's where a lot of my practice is focused. In a couple slides, we'll get into what is a traumatic brain injury or not a traumatic brain injury, but essentially any sort of trauma or major incident, accident that causes an injury to affect the brain would be classified as a TBI. A subsection of TBI is an MTBI, or mild traumatic brain injury. This is a term that's usually applied to what we know of as a concussion. So it's something, and we'll get into differentiating what constitutes mild and not mild as well, the specifics of that. But just knowing that that is a subsection of traumatic brain injury. So if you hear the term mild traumatic brain injury, MTBI, you can pretty much relate that to a concussion. A relatively new term in the last half decade or so, that's started to be used more and more, is SRC, or a sports-related concussion. So this is really a matter of preference on a professional's parts. They've started using this to be much more specific about what the injury occurred from. So just further differentiating, but it is fairly common use among practitioners right now, and it's being advocated to continue doing so and make that specific term common use. So if you've got a concussion or a brain injury that resulted from sports or a sports incident, they'll often use the term sports-related concussion or sports-related brain injury. Early. This is also relatively newly not discovered, but it's being studied more and more because it's being recognized more and more. So what happens here is this is usually the results of multiple brain injuries over time, and most of the information that's coming in, or most of the time, it's related to repeated sports injuries in sports where you're likely to sustain concussions over and over again. So football players that have been doing it for a long time, boxing, things like that. And what happens with CTE is that it seems to develop into a progressive degenerative condition where the nervous system continues to break down. A lot of the time cognition continues to break down, and they'll get symptoms akin to Parkinson's disease or Alzheimer's. And so it seems that the inflammation in the brain just it becomes an ongoing process, so it becomes that progressive degenerative condition. So that's CTE. As far as treatment protocols, they're still very much in development because it's such a new thing that we're still trying to understand. See, DAI is diffuse axonal injury. So this is a subsection of brain injury in which you don't get just a localized effect from that, but you actually get neuronal shearing within the brain tissue. So the nerve cells shear throughout. And so if somebody has an injury to the frontal lobe, hold on, I'm going to check. It's telling me I've got a loss here. I'm saying I'm connected. Okay. With DAI, people can have an injury to just their frontal lobe. So they just hit their frontal lobe, but because of neuronal shearing, they can have symptoms related to other areas of the brain because those areas are affected as a result of the inflammation, as a result of the shearing. And then blast injuries is another subsection of brain injury, specifically a result of exposure to some sort of blast or explosion. So some sort of shock wave from an explosive device has caused the injury, and we'll get into the specifics of that and different levels of that as we go. So CTE, as far as terminology, it's usually related to a repetitive injury. It doesn't necessarily have to be a time frame between injury to be called CTE. If you have some sort of concussion or some sort of brain injury, I mean, the sooner that something happens following, if you have a repeated injury soon after, the chances of severity of that secondary injury certainly increases. But the development of CTE, it's still kind of up in the air as far as, I mean, you can go years between concussions. And if you have repeated concussions, even over a fairly long span of time, it seems that CTE is a possibility, that you can still develop that. So shearing is the nerve cell, it breaks. So if you've got this inflammation, you've got the injury itself kind of rocking the brain within the skull, and so the nerve cells break apart or are torn apart or are sheared. So hopefully that answers that. Meningitis does fall into ABI, acquired brain injury, and we'll get into a list of that here really quickly. In fact, right here. So this is the differentiation, different categories of what falls under traumatic brain injury versus non-traumatic brain injury. So what's considered trauma-related brain injury is some sort of fall, an assault. So if you get assaulted or in a fight, motor vehicle accidents, sports recreational injuries, so sports injuries. There's a term that's more common now called abusive head trauma, and this used to be called shaken baby syndrome. So this is an incident in which a baby or a young child is exposed to being shaken violently or put down too quickly. Often it's the results of a parent who's lost their patience and just kind of has that reaction, doesn't know how to cope with the child, and will shake them. It's a very unfortunate incident, but that's definitely one of the causes of pediatric, some of the pediatrics that I treat, which came up as a question during the 1-hour webinar last week, is whether or not I treat pediatrics, and I certainly do. And abusive head trauma or shaken baby syndrome is definitely one of those instances. Gunshot wounds, workplace injuries, so workers' comp, treat a fair amount of that. Military and blast injuries, which, as I said, we'll discuss in just a couple of slides as well, and the specifics of that. Instances of domestic violence or child abuse, all of those will fall into trauma. And then cases that are not considered traumatic brain injury, you had asked about meningitis, which is listed there under infectious diseases. Stroke is considered a non-traumatic event. Seizure disorders, electric shock, lightning strikes is categorized as a non-traumatic event for whatever reason. Tumors, especially brain tumors. So I've got a good number of patients who have a brain tumor or have had a brain tumor, and so they had surgery for removal of the tumor and the results that come from that. Toxic exposures to different substances, drugs, inhalation from chemicals that may be around, metabolic disorders such as insulin shock, liver and kidney diseases can have a direct impact on the brain as well. The neurotoxic poisoning, which is more of your lead exposure, carbon monoxide exposure, things like that, and anything that causes a lack of oxygen to the brain. So cases of near drowning, airway obstruction or strangulation, hypoxia of any sort of kind can lead to injury of the brain tissue, and thus can lead to a lot of the symptoms related to brain injury, but aren't necessarily the result of a direct trauma. So I talked about there being a differentiation between mild traumatic brain injury and basically not mild traumatic brain injury. Anything that's not considered mild is considered either moderate or severe. And so to be considered mild, it has to meet certain limitations or fall within certain limitations. So loss of consciousness cannot be longer than 30 minutes. Some people will not lose consciousness at all. Some people will lose consciousness for a couple seconds. As long as it falls within that less than 30-minute window and meets the other criteria listed in mild, it's considered a mild traumatic brain injury. So change in consciousness or retrograde amnesia for less than 24 hours. No focal neurological signs. So if you do neurological testing, especially in imaging, nothing really shows up generally with a mild traumatic brain injury, which is that last thing listed there. Neurocognitive testing can be rather inconclusive, so you may not find much at all. People can kind of sometimes just shake those injuries off and not seem to be too affected when you run through standard sideline testing or neurological testings. With moderate to severe injuries, the loss of consciousness is generally more than 30 minutes. Your post-traumatic amnesia usually lasts more than 24 hours. The Glasgow Coma Scale, which we're not going to go directly over in this, but it's essentially a scale that that gauges their level of consciousness and awareness. So how reactive they are to their current environment and how aware they are of their surroundings. So as low as 3, meaning that they are rated low in a level of awareness or consciousness of their situation. Often they'll have focal neurological signs. Neurological testing is very much needed in this because cognition can be very much affected with a moderate to severe injury, and imaging is considered diagnostic. A lot of the time, even with a moderate to severe injury though, traumatic brain injury or brain injury in general can be rather elusive as far as imaging goes. So people can have very severe symptoms and as a result of their injury, but diagnostic won't show anything. And so that's one of the difficult things, especially for allopathic biomedicine practitioners, is nothing will show up on imaging, so it's really difficult for them to kind of pin down exactly what is affected and where treatment needs to be focused. Psychological causes of TBI. Cell necrosis from radiation therapy is definitely a possibility. I'm not going to get directly into specifics today because we've got so much to cover, but it can definitely be a cause. Psychological causes of TBI definitely can be a component as well. So that domestic abuse, that includes psychological abuse, and that'll actually be a very prominent portion of the discussion tomorrow if you're attending the PTSD class. So if you're interested in the psychological causes of TBI or the correlation between PTSD and brain injury, definitely tune in tomorrow. All right, so you've got those two categories of mild traumatic brain injury or mild brain injury and moderate to severe injuries. And knowing that those two things exist is very important, but even more important is to understand that when something is categorized as mild versus severe, that is only talking about at the time of injury. So those list of things, the loss of consciousness for less than 30 minutes, the amnesia for less than 24 hours, that descriptor of mild gets pinned on of what happened at the time of injury. That has absolutely nothing to do with any time after their immediate response to the injury. So somebody can have what's considered a mild brain injury, but still have very severe, long-standing, sometimes life-changing, life-debilitating symptoms. And so it's very important as a practitioner not to get caught up and writing off their injury just because it's called mild does not mean that the body did not continue to react, the brain did not have a significant amount of inflammation during the healing process that caused additional injury, and things like that. So very important to be aware if somebody comes in and say that they had a mild brain injury but are experiencing severe ongoing symptoms, that mild is only an indicator of that time of injury. All right, so one of the main factors that Dr. Carrick, who is a neurologist and heads the Carrick Institute and teaches functional neurology, if you're familiar with that at all, he says that the degree of irritability that a patient has is the #1 key indicator as far as how severe an injury is. And this may be due to how much inflammation a person is experiencing in the brain or systemically, but as a result, somebody who has a more severe injury will tend to be much more irritable, and that can be their interaction with you as a practitioner. That can be self-reported, that they feel very irritable. That can be reported by a third party, so a significant other, child, parent, caregiver, anybody like that. But that level of irritability really seems to have a direct correlation to how severe that individual has been impacted by the injury. So we're not going to get too much into spinal cord injuries today. That's certainly part of the central nervous system, and injuries to the spinal cord or injuries to the sacral area can have a direct effect on brain injury, and that's not something that I have in the slides today. But it is important to realize, especially in sports-related injuries or instances where there are falls, that trauma to the spine or trauma to the sacral area in the lower portion of the spine can have a further effect that ripples up through the spine and the central nervous system and can have an effect similar to a brain injury. You can experience a concussion with trauma to the sacrum. So that's not usually something I get into, but it is an important point. But yeah, we won't get too much into the treatment of spinal cord injuries specifically. So we had touched on blast injuries. These are also called blast-induced neurotraumas, or BINT, and they fall into a hierarchy of different types of injuries that can be sustained as a result of some sort of blast or explosive. So a primary blast injury is a direct impact to the body from the blast force itself. So there's an explosion, that force directly hits you, and it shakes through your whole body as well as your head and can cause injury to the brain tissue. A secondary level blast injury is where you get an injury due to energized debris, so something coming at you like shrapnel that then injures your body and causes some sort of concussion. A tertiary blast injury is where the body, your body, or the patient's body, is displaced by impact. So it gets displaced and hits the ground, hits a wall, or something else. So there's an explosion, the body is thrown, and you end up hitting up against something, causes injury to the brain. Quaternary blast injuries is exposure to some sort of toxic substance as a result of the explosion. So if you have inhalation of even debris or toxic substances that may be in there. And a lot of the blast injuries, as you'd imagine, are related to military personnel who are out on the front lines and exposed to some sort of explosion, but not always. You can have workers that work in situations, or even gun-related injuries and things like that. You can have different sorts of blast injuries, but the vast majority of what I see in my practice are usually military personnel. And so there are some special considerations as far as that goes, which we'll get into a little bit later. So what happens with a blast-induced neurotrauma, what happens with a blast injury is, firstly, there's a direct interaction with the head through direct passage of the blast wave. So the blast itself shakes the body, but also the wave, the shock wave of that can pass through tissue. Oh, we had a little glitch there. I think we're okay, hopefully. The second component of a blast injury is that you get the transfer of kinetic energy from the blast wave itself, and it goes through the central nervous system and through the blood vessels and shakes everything and causes a disturbance through systemically. And so it's been reported cases of brain edema and considerable metabolic disturbances within the brain as a result of blast injury. So this is rather unique about blast injuries, is that it shakes everything around and seems to throw off the metabolism of the brain functioning itself. So as you can see there, significantly decreased glucose, magnesium, and ATP concentrations, increased lactate concentrations, and impaired sodium and potassium functions have all been correlated to blast injury. So impairment of sodium and potassium functions, you've got impairment of the nerve cells themselves in being able to function and properly fire. So it can be fairly significant as far as its impact. Evidence is accumulating that a primary blast injury, that's the direct injury from the blast itself, affects the internal organs that have fluid interfaces, so a lot of fluid within either the lining of the organ or within the organ itself, such as lungs and the liver, that allows for a transfer of all that kinetic energy, just that big blast of kinetic energy. It causes a sudden shift in the pressure within the organs. It increases the pressure and causes an overall systemic vagal reflex. So the person can experience trouble breathing, rapid breathing, slowing down of the heart, dilation of the peripheral blood vessels, where blood pressure drops. And so once again, with a blast injury, often you're looking at a very systemic effect from that, and rather unique in its presentation. With BOBS, what I consider direct injury from the spinal cord structures and secondary to the brain, it can be both. So it can have a direct effect on the brain itself as a result of the blast waves shaking the head or shaking the brain, which will cause a direct injury itself, or like we talked about, spinal cord injury, or if it affects other areas of the brain or areas of the other areas of the body, that it can have that secondary effect on the brain. So it can work both ways. So why should we bother even learning about traumatic brain injury? Like I said kind of in my introduction, it's a lot of people experience it. It's not something that we're necessarily trained in most of the time. A lot of practitioners, medical practitioners, even your MD neurologists, speech language pathologists that often work with people with a brain injury don't get specific training in how to focus on that, or what the standard treatment protocols are. And it kind of behooves us as practitioners, we're not necessarily seeing acute cases immediately after brain injury most of the time. A lot of the time we're seeing people who have had an injury a couple months, 6 months, a year, several years out. I mean, I've had people who have come in and I've treated several decades after they sustained the injury. But it happens a lot, and a lot of people have sustained this type of injury. So over 2 million people every year are estimated to sustain some sort of brain injury. The trouble with this statistics is a lot of the time it's not reported. So if they don't seek medical care, then it's not really reported as a statistic. So chances are it's suspected that that number is much, much larger. You know, sports injuries where people will attempt to just shake it off and move on, or work injuries, or just falls where they'll experience concussion and maybe take some time to themselves but not seek out medical care, so it doesn't really get tallied within that number. But the estimated number of people out there living with residual effects, this is after effects, sequela of brain injury, is about 5.4 million people. This is a U.S. statistic. This isn't worldwide, so keep that in mind as well. So it's suspected that over almost 5.5 million people in the U.S. are living with some sort of sequela as a result of a concussion or a brain injury. And it is considered among the leading causes of death and long-term disability. Within the U.S., the long-term disability is a key component here, because a lot of people have ongoing symptoms and ongoing effects that can last a lifetime if it's not properly addressed, or sometimes that it can last quite a while and change many aspects of their lives. And we'll get into those specific symptoms in just a bit. The estimated impact of brain injuries is about $76 billion in the lifetime, within the lifetime of an individual in 2000 alone. So within the U.S. in 2000 alone, it was estimated that $76 billion of medical costs and those things had accumulated. So it has this massive economic effect. And it was estimated that in additional $137 billion value in quality of life and loss of quality of life as well. So it has not only a dramatic impact on the individual, but a very big impact on the economy as well, and on the financial situation of a lot of individuals needing ongoing care, to whether it be caregivers or medical care, in working through these sorts of things. So it's a really big issue, is the key thing there. A lot of people are living with it. It's having a huge impact on their lives. These people are going to come to us as patients, and despite that, it's something that's rarely discussed or really gone through as far as medical treatments. Even within society, it's become more well-known and more openly discussed as a result of a lot of the military personnel that are coming back, that are now experiencing those blast injuries that we talked about. So what we're seeing with that is that a lot more military personnel, because of the improvement in body armor and protective gear, it's saving lives. Individuals are living through those experiences, but they're having residual symptomology because of the exposure to the blast and their experiences there. So if you look into the literature for brain injury, a lot of the time it'll be referred to as a silent epidemic. Reason for that is it's a very big issue, but gets very little attention oftentimes. So a lot of people are not familiar with the effects of what a brain injury does, how it impacts somebody, unless they've had some sort of direct interaction with somebody who's sustained a concussion and brain injury and had these sort of symptoms. So I meet a lot of people who, before their family member had a TBI, they had no idea what a TBI is. With the ongoing, it's also gotten a little bit more attention as a result of some of the sports-related injuries and the focus on preventing concussion, and each state now passing regulations as far as when individuals are allowed to go back into the field after sustaining an injury. So it is getting more attention, but definitely not what it's deserving as far as how many people are being impacted by this. Let's see, just reading over some of the questions here. Would you include as silent epidemic the PTI from American football? Yeah, absolutely. I mean, that's a very common cause of concussion or brain injury. So a lot of individuals will sustain concussion as a result of that. Let's see. Okay. So let's go ahead and get into some of the Chinese medical aspect of this and how the brain is looked at from a TCM perspective. So the term for brain in Chinese medicine is Nao, and it is considered an extraordinary fu, or an extraordinary organ. So instead of being elaborated on like the 12 primary organs, it falls into the category of extraordinary fu, of which there are 6. So you have the brain, the gallbladder, the bone, blood vessels, marrow, and the uterus. So as we'll talk about in a little bit, a couple of those directly impact the brain as well. So the brain is considered the sea of marrow. So you've got that correlation with marrow itself there. And how the brain is said to operate is, or receive its energy, is via the kidney organ system. So the kidney yin generates, the jing ascends up the spine via the governing vessel. And so that jing moves up and then is up into the storehouse of the brain. And so because of that, it's considered very yin in nature. The chapter 81 of the Su Wen directly says that the brain is a yin organ. It is said to have a direct relationship with the eyes, and we'll get into that a little bit more down the line as well, and how that falls into Western models of the brain, and that very intimate connection with the eyes. So that's one place where there's a lot of overlap and is very true. And the extraordinary vessels of the yin chao and the yang chao mai are said to have a relationship with the inner brain. And so as you're looking at treatments, you can take a look at whether or not the yin chao or the yang chao is appropriate to address that. Of course, that has those vessels have a lot to do with movements, and also have that correlation with the eyes and in the ability of the eyes to open and close. So that is a connection that is often referenced. The Taoist texts refer to the brain as the Ling Fu, or the spiritual depot, the depot of spirituality, and it is looked at as essentially a canopy sitting atop the head that attracts, making sure I didn't get a little note there, that attracts subtle emanations from the heavenly yang. So it comes in via the GV20 area, the top of the head there, and acts as a transceiver between the mind, the body, and the environment. So it takes in that heavenly yang, that information from the external, and is then integrated into to allow for functionality between the Shen, the mind, the body, and the environment. See, you guys are putting a picture of me up there, so I'm going to try to stop my webcam real quick. We're going to try to restart it and see if that makes a difference. If not, feel free to flash star my mug up there, and that'll work fine. Hopefully everybody can hear me okay. All right, continuing on as far as the Chinese medical descriptions of the brain, which there's not a lot of. It wasn't an organ that was thoroughly elaborated on. It was called, and that's not here on the slides, but it was called the cleanest organ, and that is suspected to be considered kind of an extrapolation of the blood-brain barrier in the fact that very little can get into the brain, and it's also easily contaminated if something does get in there. So it's very susceptible to injury coming from any sort of external influence internal lost it there, but the brain needs to be protected, and the Chinese medicine texts refer to this as the cleanest organ within the body. So there are descriptions of excess and deficiency conditions in the sea of marrow, which again is the term for the brain. So in an excess within the sea of marrow, an individual is said to be alert and robust with a lot of strength. One fulfills abundantly the number of years allotted. So if a deficiency in the sea of marrow is experienced, then it says when the brain turns around, you get a term suspected to allude to vertigo, and the ears buzz, so you get tinnitus. The legs are weak and a kind of paralysis. One has visual disturbances. The eye can no longer see. One is slow and lazy and likes to lay down quietly. So, our classical descriptions of brain disorders as far as excess and deficiency. Later texts do attribute more function. So as time passed in the 19th century, 1800s, and as there was a little bit more exposure to Western anatomical understanding as well, they put more function and attention on the brain itself, especially when it relates to memory. So there's a quote here coming from the book The Extraordinary Fu. It says, "The Jingji, the spiritual mechanisms of the memory, is not in the heart, but in the brain. The heart is the pathway by which the qi comes in and goes out. So how could the heart produce the spiritual mechanism of accumulation, that yin accumulation of marrow, and retaining which is called memory?" So they started to attribute more functionality to the brain, more attributes to the brain. And here's a big long quote that we'll go through real quick, which is just a later description of the function of the brain. So the Yishu in the 19th century stated in The Art of Medicine that when the brain in its marrow is pure and clear, then the spiritual efficacy can find somewhere to stay. But if they are unclear and disturbed, then you have stupidity and bad perception through the sense organs, because they are contrary of clarity and the ability to penetrate. Which are the qualities necessary for intelligence, perception, hearing, and vision? When one thinks, the qi of the heart rises in free communication with the skull. When the brain and the marrow are in a good state of fullness, then thoughts come easily. But when you think a lot, the fire of the heart burns the brain, and the head spins. So again, that's that vertigo. The vision becomes disturbed, and the ears buzz. You get tinnitus. This shows that the marrow has been injured. The marrow is rooted in the essences for its production, and below it is in free communication with Mingmen, the fire of life, and the Dumai, the governing vessel, which is also present at its place. The fire of Mingmen, or the yang of the Dumai, warm and maintain the warmth of life, and then the marrow. which is in free communication with the essences of the kidneys, and with this fire overflows with power. But if through desires and emotions Mingmen is injured, then there will no longer be this rising and warming, but a kind of collapse downward. The brain and the marrow are deprived of their nourishment, and then they deteriorate. So all of those, basically what that's going through and saying is it's attributing a lot more functionality to the brain, and that the Mingmen fire is very important. The Jing is very important in nourishing the marrow, and the interaction of those along with the heart and maintaining emotional balance in the proper movement of the heart and heart blood, which we will get into tomorrow with PTSD and the relation between heart yin and emotional shock and how that impacts. But they did definitely go through and start discussing the brain a little bit more over time. Audio is still good, going through, okay. All right, so we're going to spend a good amount of time going over neuroanatomy and neuropathology. This is going to be a lot of information, so you can always reference back to the slides. You've got a month to continue to watch this, reference back. But it is very important to understand the functionality of the brain, the different portions of the brain, and what an injury to that area affects. Both in case somebody comes in and says, okay, they had an injury and hit the front of their head, and so you would suspect frontal lobe injury. But if they come in and start saying that they have trouble putting words together, they can't sing, they're having memory issues, how to differentiate what areas might be affected, so that you can work both in a general sense with the brain as well as being able to provide advice or exercises or treatment protocols that will directly work in the direction of the areas affected, which we will also get into. So let's start with the brain stem and see if I can make this just a little bit larger here. I apologize for some of these slides and the small text, but I wanted to try to get as much on there for your reference as possible so that you can take a look at the slides even if we don't necessarily go over all of it here in the discussion itself. So the brainstem is made up of several different portions, and essentially what it comes down to is that the brainstem regulates a lot of the autonomic functions of the body. So everything from sleep patterns to breathing to heart rates to general metabolism. So the four of the main components of the brainstem, first up there on the top is the pons. The pons helps regulate sleep, respiration, swallowing, bladder control, the ability to hear, one's equilibrium, which can often be a problem for a lot of individuals after they've had a brain injury, is their equilibrium or their balance will be off, and that's something that you can use both as an objective test to gauge both where they are at and what sort of an improvement they're making. We'll talk about the relationship between that and the dorsolateral prefrontal cortex a little bit later. But gauging one's equilibrium can be helpful both diagnostically and in gauging improvement. The pons is also responsible for a sense of taste, eye movements, facial expressions, facial sensation, and posture. It's suspected to have a role in dreaming and sleep paralysis as well. So if you have somebody experiencing sleep paralysis, or if you've ever experienced that, that's where somebody wakes up or semi-wakes up, but they have an inability to move their body. And often it will come with nightmarish visions or a sense of some daunting either individual or something. It's like essentially a waking living nightmare that people experience with an inability to move their body. So they're semi-conscious or conscious but unable to move. So they suspect that some of that may be related to the pons. The medulla is another portion of the brainstem, and it regulates sleeping, heart rate, blood pressure, automatic functions such as coughing, sneezing, swallowing, or vomiting. So that is your medulla oblongata. The midbrain is made up of a few different portions, or can be broken down into several different portions. The periaductal gray is one that helps regulate or control motor vocal aspects of emotional expression. It's things like laughing, crying, howling, plosive sounds, where the big B's or P sounds, that you got the p, 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 facial expressions, and things like that. So if the periaductal gray is affected, people may spontaneously make those sort of vocalizations. So they may just go p, 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 not necessarily that rapidly, or they may have spontaneous crying or spontaneous laughing, and so that can be an indicator that possibly the pons will be affected. There are a couple areas where that can come about as well. Another portion of the midbrain is the superior colliculi, which has it's essentially a multimodal assimilation area that orients an individual toward their external stimuli and movement. So it takes in incoming information and helps the individual orient themselves sorry, to their external environment and what's going on, and how to engage that with active movement. The inferior colliculus detects and analyzes and localizes auditory stimuli in various sound sources. So it just takes in sounds from around you and analyzes that and determines where it's coming from. And again, as we go through this, a lot of mentioning what these areas of the brain do is a key indicator of what symptoms they may have if that brain area is affected. And so that's why I'm going to go through and list all of these, is that if you've got somebody who can hear sounds but has trouble figuring out where it's coming from, even with eyes open, then it's possible that the inferior colliculus is affected. The reticular formation takes and integrates sensory information received from the skin, the muscles, the joints, and the vestibular system, which we will talk about specifically in a little bit, and it coordinates a responsive behavior to that. So it's taking in a reticular formation, takes in all of this sensory stimuli, and determines what to do with it and responds to it appropriately. Often this is a rather primal portion of the brain, so the responses are usually very reflex-like. So after the brainstem, and we're going to kind of work up through these in an evolutionary sense, and it's also in a developmental sense. So after somebody is born, brain development continues up into adulthood, up into the early 20s, but certain areas develop during certain time periods. And so prior to birth, around birth, and through the first year or so, the child is operating from a lot of these what are considered lower functions, so the brainstem, the cranial nerves, the cerebellum, that we'll talk about in a little bit. But recognizing that these are getting increasingly complex in nature, and so it's both the order in which evolutionarily the brain has developed over time, and also the steps that a child or an individual goes through as they're developing cognitively. So we'll start with the most basic, which is those brainstem autonomic functions, and then we can move into the cranial nerves here, which also regulate a lot of autonomic functioning. So most of you, I'm sure, are familiar with the nature of the cranial nerves, but we'll go through each one of these just so you've got it there for reference and know exactly what they are doing, and again, if they're affected, what kind of symptoms a person may be experiencing. As far as treatment of the cranial nerves, we'll touch on it a little bit later, and how I usually approach it. For the cranial nerves specifically, I use a lot of occipital lobe areas in the base of the skull, or I use Yamamoto new scalp acupuncture. Has points on the anterior of the skull around the GV24 area. I know you can't see my head, so I was pointing to that area. but along the front of the scalp, between about GV20 and GV24, there are points indicated for each of the cranial nerves, and I have found positive therapeutic effect or clinical effect from those. So let's get into the cranial nerves here, and then I think we might make it through the cranial nerves before the first break, or we might make it through the cerebellum. We'll see. The first cranial nerve is the olfactory nerve. It primarily regulates smell and taste, or takes in smell and taste. So if somebody has an injury, what you run into with the olfactory nerve, or what you run into as far as a brain injury or a head injury, is that a plate in the front of the skull, the cribriform plate, can move as a result of a shock wave or movement of the injury or impact, and it can fracture the olfactory nerve itself. And so if this happens, somebody loses their sense of smell. It's called anosmia. And if this happens, but it's only in one side, and so if the symptoms are unilateral, a lot of the time the patient will have no idea that they are really experiencing it, because they're still getting their sense of smell from the other side. But if it is bilateral, then they'll notice it. So what you can do is test unilaterally. So you can do a test of their olfactory function and just get an essential oil or something, and have them smell while covering one nostril, smell with the other nostril, and then switch sides and make sure that that sense of smell is not affected. So somebody can also experience olfactory hallucinations with this. So tumors, seizures, or an inferior temporal lobe injuries can also do this. So there's some differential diagnosis that needs to be done. But if somebody is experiencing a sense of they're smelling something, but nobody else around them is smelling it, they may be having olfactory hallucinations, and that can result from the cranial nerve being affected. Yes, like COVID symptoms. The second cranial nerve is the optic nerve. It takes in a lot of visual stimuli, so what people end up with if they have an injury affecting that nerve is that they'll get visual defects. A lot of the time they'll get what's called visual neglect. So certain areas of their visual field may be affected, and they may not experience any sense of vision within that region of vision. So for instance, you can cut it up into quadrants, and say if somebody doesn't see anything from their upper right quadrant of their vision, then that's considered a type of visual neglect. So if it's bilateral, it indicates that there's either an injury to both hemispheres of the brain, or that the retina or the optic nerve is affected before it actually goes into the optic chiasm. So it can also be a unilateral issue, and this usually indicates that the injury is localized to one side of the optic tract. So you can do visual testing if they're reporting. You can go through and test those sorts of things and see if the neglect is unilateral or bilateral, or if the defect is unilateral or bilateral. Down to the last two things down here is some of the differential diagnosis. So if they have temporal lobe injuries, it's associated with upper quadrant defects. If they have superior parietal lobe injuries, which we'll get into, it's associated with lower quadrant defects. So those are just kind of references for you for later as you're going back through this material, if you're going to use it for differential diagnosis to figure out what areas might be affected. So that did work. Okay, great. Third cranial nerve is the ocular motor nerve. So this controls the muscles of the eyeball, moves the eyeball around, with the exception of two muscles, which are the lateral rectus and the superior oblique, which I have a diagram here for you. So if you looked right in the middle of the left-hand diagram, the lateral rectus muscle, and then the superior oblique is the one in the left diagram at the very top left-hand corner. So those are muscles that are innervated by the trochlear nerve down below, but everything else is innervated by the ocular motor nerve. So if they have injury to the ocular motor nerve, issue is going to be that they have trouble moving their eyes. So there is a lot of, we're not going to get too much into neurological testing. I'll make mention as we kind of, as appropriate, but we've got only so much time, so we're not going to go through all of the neurological tests, but there are a lot of visual tests that you can use to gauge how smooth the movement of the eyeball is, how reactive it is to stimuli, and different things like that. So what you find with oculomotor nerve being affected is that it also controls the pupil, and so the pupil may not react appropriately, and they'll have trouble gauging or following your finger. So that's a quick, easy test that you can do with them. This nerve also innervates the muscle that raises the eyelid. So if this nerve is affected, they may have a droopy eyelid that can be bilateral, that can be unilateral, and so with that you get symptoms akin to Bell's palsy. Very different origin as far as what's going on there, but that can be a symptom. So if you happen to see that presentation in clinic, you can check out and see if they have any trouble with the movement of their eyes by following your finger, and that will kind of point you to the oculomotor nerve. So as you can see there, if it's damaged, they might have an inability to rotate the eye upward, downward, or inward. The pupil may also not respond to direct light as a result of the pupil not being properly innervated. So as we talked about the trochlear nerve, the next one, cranial nerve 4, is responsible for those other two muscles that move the eyeball in and down. So if you think about somebody going cross-eyed, if they have an inability to do that, well, some people can't do it anyway, but those muscles are what allows the eyeball to do that. And so that you can attempt testing that. If they weren't able to do it before the injury, they won't be able to do it after the injury. But kind of a way to test that, and it is the trochlear nerve is said to be the most common cranial nerve to be damaged from head trauma. So worth testing. Yeah, again, I do apologize for the small text. There's a lot of information, and I tried to consolidate it into only so many slides, so you weren't ending up with 200. You've only got, I think, 120, something like that. So there again, muscles of the eyeball that you can reference, the superior oblique and your lateral rectus muscles are the ones innervated by the trochlear nerve, and everything else is innervated by the oculomotor nerve. Okay, moving on to the next cranial nerve is the trigeminal nerve. It's cranial nerve number 5, primarily is involved in jaw movement and facial expression, along with cranial nerve 7, which we'll get into shortly, obviously. So with the trigeminal nerve, you can run into trigeminal neuralgia, which, if you're not familiar with trigeminal neuralgia, is, often a very intensely painful nerve sensation along the side of the face. And so if you take a look at the diagram over to the right there, the upper portion, the trigeminal nerve has 3 branches, one that runs along the jaw line, one that runs along the zygomatic arch below the eye, and then one that runs along the temporal area along the side of the eye. And so clinically, I've had pretty great success with trigeminal neuralgia in most cases, getting in there and doing some local work to try to either improve nerve conduction, or if there's a lot of compression from muscles in that area, working to release those muscles and allow for the nerve signaling to reconvene. The causes, just because somebody has trigeminal neuralgia does not mean that the trigeminal nerve is affected from brain injury. However, it can happen from compression of muscles in that jaw area. So you kind of want to suss that out and see what the most appropriate approach is. The trigeminal nerve is responsive to temperature, touch, and pain of the face, teeth, mouth, and the mucous membranes of the nose, cheek, tongue, and sinuses. And so people can have difficulty chewing. If it's hyperactive, some people can have TMJ symptoms or something akin to not off jaw, but the jaw will be very, very tight, or those masseter muscles will be very tight. If it's severe damage to the nerve, you can have ipsilateral, so same-sided atrophy, or complete paralysis of the temporal or masseter muscles. Can happen a lot with dental work and surgery, and that's also very true. Let's see. Yeah, guys, I'm sorry about the webcam thing. I'm not quite sure what's happening here. We're going to do the best that we can and move forward. And then we've got a break coming up in about 15 minutes. I'll mess with it a little bit and see what we can do. Cranial nerve 6 controls horizontal eye movement. It's the abducens nerve, and so it controls vertical gaze, which is the ability to follow a movement smoothly, and that is the vertical gaze is linked to the pontine midbrain, but horizontal eye movement is attributed to the abducens, and so somebody can experience lateral gaze paralysis. They have an inability to do that, and if there is paralysis of those muscles, they might experience double vision, or diplopia. So double vision is not terribly uncommon with brain injury, so it's definitely something worth asking when you're asking about any visual problems, to ask them if they're having any sort of double vision, and whether or not they experienced that before the injury. The 7th cranial nerve is the facial nerve. It controls the motor functions of the nerve itself, so movement of the face, the lips, the ability to retract the lips, moving of the eyebrows, and closing of the eyelids. So here you actually have symptoms much more like a full-blown Bell's palsy. People might be unable to wrinkle their forehead, or purse their lips, or show their teeth. So all of these are movements that you can have somebody go through and do for you, or attempt to do for you, and see whether or not it's affected. They may also lose their sense of taste because the facial nerve innervates the anterior 2/3 of the tongue. The posterior 2/3 is innervated by the 9th cranial nerve, which we'll get to in a second. But before that, you've got the vestibular nerve. That's your 8th cranial nerve. It innervates the inner ear and controls equilibrium and proprioception, so one's ability to balance themselves and realize where they are within space and accommodate appropriately. So people can get abnormal sensations of movement. They may feel like they're moving without actually doing so. They can experience vertigo, nausea as a result of that. They can have a tendency to fall or get motion sickness without actually moving. So stationary motion sickness. People can experience deafness and tinnitus. It may feel as though they're being pulled to one side, or if you watch them walk in, which is something that I will always do with a patient, especially if I know that they've had a brain injury, is watch them as they walk in. And we may do some additional gait testing where I have them walk up and down the hall or back and forth a little bit. But with the vestibular nerve, they may lean to one side, or they may actually physically start veering the path in which they're walking over to one side, and so that's usually the side that's affected. And the vestibular nerve has a lot of connections with with a lot of other cranial nerves. Vestibular therapy, which is done by a few different types of practitioners, can be very helpful because a lot of the time the vestibular system can be very much affected following a brain injury. I have a lot of patients who come in with tinnitus or with dizziness, and doing points that can help regulate the vestibular nerve or the vestibular system. So points near the back of the ear, like triple Warmer 17, can be helpful in regulating the vestibular system. So knowing that that is affected, I wouldn't say that's definitely not a catch-all for tinnitus, which we're not going to get into specifically, but as far as treating that, for people who have had some sort of brain trauma, especially if it's something that's like a whiplash condition, or they hit their head against something, or a car accident where they hit their head against the windshield or the steering wheel, and there's that impact. Sometimes there will be compensation in the musculature of the neck or at the base of the skull, and that will compress on the vestibular nerve or compress on the inner ear and have an effect there. And so sometimes, in some cases, with dizziness or tinnitus, doing points in that triple warmer 17 area, gallbladder 20 area can be really helpful, either in just releasing those muscles or affecting that nerve. So I've had patients where with a gallbladder 20, it almost works as you stimulate the needle and you turn the needle, it almost is like a radio dial turning the tinnitus up and down, finding just the right release in that area. So kind of interesting, and definitely something that I found that rather unique in treating brain injury or trauma cases, but can be very helpful for a lot of people because that ongoing tinnitus or ongoing dizziness can really impact somebody's life. And yeah, definitely effective in children with recurrent ear infections as well. The ninth cranial nerve is the glossopharyngeal nerve, and so like I alluded to earlier, that innervates the back third, of the tongue, and so it primarily regulates tactile, thermal, pain sensations of the tongue, and affects the vagus nerve, which is the next one down there, cranial nerve 10. And so people can lose that sense of taste, that sense of sensation in the back third of the tongue. I keep wanting to say half. They can lose their gag reflex, or it can be rather painful when swallowing or coughing because it will stimulate that nerve. The vagus nerve is a biggie, so cranial nerve 10 controls everything from swallowing, breathing, speaking, airway movement, and innervation of the viscera, the internal organs. And so the vagus nerve goes through and innervates all of the laryngeal portions that control that swallowing, breathing, speaking, and then goes through and innervates all of our major internal organs. So as you can see in the diagram there, lungs, heart, liver, spleen, pancreas, stomach, and the intestines. All of that can be affected by the vagus nerve. And so if the vagus nerve is hyperactive, it's going to have a direct effect on all of your internal organs and the regulation of such. So there are a number of different ways as acupuncturists that we can create a generalized vasovagal response that will help downregulate the response of the vagus nerve. Again, sometimes working in that triple warmer 17, gallbladder 12 area, doing auricular points, which we'll talk about auricular more specifically later, but doing some of those can have a generalized vasovagal response that'll help downregulate or re-regulate the vagus nerve. And of course, there are a number of different ways of approaching the vagus nerve as well, beyond just that, but I won't get too much into that because we want to be mindful of time, which we are coming up on. So the 11th cranial nerve is the spinal accessory nerve, or the accessory nerve. It controls the muscles of the throat, the larynx, the SCM, and the upper trapezius muscles. So if that is affected, people will usually have ipsilateral, same-sided sagging of the shoulders. So if somebody comes in and one shoulder is just slumping, or if they're having trouble turning their head, especially against resistance, then you can suspect that the spinal accessory nerve may be impacted. The hypoglossal nerve is the last cranial nerve. It's the 12th and controls tongue movement. So if somebody has tongue weakness, atrophy, or deviation, take a look at the hypoglossal nerve and it may be affected. You take a look at the picture that we've got there and you've got that tongue deviation. Of course, in Chinese medicine, we take a look at the tongue and we see that deviation, and we usually draw that first correlation to wind, right? So that can be the case, and you got to do a little bit of differential diagnosis there and suss through, and we will talk about wind as a pathogenic factor in itself a little bit later in this. But also know that if they have tongue deviation, it can be a direct effect of that hypoglossal nerve being affected. So we'll come back around to that in just a little bit. Yeah, absolutely the vagal nerve and diaphragmatic conditions as well. Let's go ahead and take a 15-minute, well, let's go through cerebellum real quick. We should be able to make it in the next 8 minutes, and then we'll be closer to 10:30. So the cerebellum is at the lower portion of the brain there, as you can see. So around that GV16, gallbladder 20 occipital area. A little bit lower than the occiput, but cerebellum, when you're generally taught about the cerebellum, you learn primarily about motor movement, and it does definitely control that. So in terms of motor movement, it works to consolidate smooth movement, smooth and coordinated movement of the body within space. And so if the cerebellum is affected, then you're going to see things like gait ataxia, in which they have a loss of balance or things are not moving smoothly. They may experience vertigo. They may experience hypotonia, so the muscles may atrophy or they may not have sufficient tone. Individuals might have involuntary motor sequences, so they might have random movements that are not intentional, or they may have intention tremor, in which they experience shaking upon trying to initiate a movement. So that's very different from a standing tremor, where regardless of whether or not they're trying to move a limb, so if they're trying to move their hand or move an arm, and it's upon initiation of that movement or trying to move that limb that they'll experience a tremor. There's a genital asynergesia, which is just a term that basically means lack of motor coordination. So they may have trouble with voluntary movements as far as force goes. So they may use too much force, they may use not enough force. So you can have somebody press up against your hand, press up against resistance, and you can tell them to do lightly and to press with a lot of force. And if they're not able to regulate that a fair amount, then the cerebellum might be affected there. Accuracy of where they're moving, so they might try to, you can test that by having them reach out and touch your finger, for instance, or reach out and touch something, and if they're off target, then that can be an indicator. Range, meaning that they might point past something, or if they're trying to touch something, they might not get there, or they might try to go too far. They have a difficult time determining the distance in which they need to move, or rate. So you can do that. An exercise that you can do for the cerebellum to help stimulate it is to have them tap along to music, keep the time of the music, or keep the time with a metronome. And an inability to do that, or cerebellum injury, can affect the ability to do that, but by practicing that, it does stimulate the cerebellum. So you can integrate that into somebody's kind of exercises or homework that you send them home with. And they may have an inability to make rapid alternating movements of the limbs. So if you have them, one example of that is like with a punching bag. You punch with one arm and then punch with the other, or punch into the air, one arm and then the other arm. And by doing that rapidly, or kicking or tapping one's foot, right foot, left foot, right foot, left foot, doing that back and forth, or tapping one's hands, that can again help stimulate the cerebellum as far as a treatment approach or an exercise, but people will lose the ability to do that or have a difficult time doing that. Involuntary movement, such as a head tick can definitely be part of that. So, and tactile hallucinations. Yeah, you're absolutely right. Which is part of the other portion of what the cerebellum does. It has an impact on visual and verbal functions as well. So it's less talked about than the motor functions. usually as you're going through and generally learning about it. But if somebody does have an injury to the cerebellum, they can have trouble tracking movements, or have a difficult time determining what a movement trajectory is. So if you throw something, they may lose track of where that object is going to go. So again, it's something that can be objectively gauged and kept track of. If you know that an injury is there, keep track of that as an objective means of showing improvement, hopefully. We already talked about falling short or going too far when they're trying to touch or grasp an object. So if they're trying to grab something, you have a ball on the table and they try to grab it. If they overreach or they don't reach far enough, that can be an issue. Nystagmus is involuntary slow or fast lateral movements, usually to the side of the lesion. So if you pay attention to their eye movements as they're tracking something, you move your finger across their visual field. If you see those really fast involuntary, well, not always fast, but you see those involuntary movements of the eye just kind of twitching back and forth, it's referred to as nystagmus and can be part of a cerebellar injury. Dysarthric speech, they may have difficulty putting proper words together or pairing words together too. So you can do tests for that as well. There are specific verbal paired tests out there that you can have for an individual. And then something that is not too often talked about as far as the cerebellum goes is its function in emotions. And so the cerebellum has a lot of strong connections with the frontal lobe and the limbic system, which we'll talk about after break. The limbic system is primarily the emotional center of the brain. The frontal lobes is primarily your cognition and higher rational thinking and deduction areas. And so those strong connections definitely play into one another. And because of that, and you can see there that the cerebellum has an inhibitory effect on the limbic system. So when the limbic system is overactive, which again we'll get into, but basically when the emotions are in overdrive, the cerebellum can act to subdue that and inhibit that a little bit. So if somebody has an injury to the cerebellum, they may experience an increased rage response. This is referred to as a sham rage. The reason for that is it's not necessarily a response to a stimuli. It's not something that just pisses them off and then they feel a lot of rage. It can come seemingly from out of nowhere, and so it's a response to the firing of the brain region. They may have a general hyperactivity, autonomic function, such as heart rate, blood pressure, respiration, and gastromotility. So the movement through the digestive tract can all be affected. You can get people who experience schizophrenia-like psychoses or possible autistic-like symptoms have been positively correlated to cerebellar injury. So if you start seeing those things that develop following an injury, worth looking into or possibly doing some exercises to stimulate the cerebellum and see if improvement occurs. So next we'll get into the occipital lobe. Sorry about the small text again, but let's do that after break. Everybody okay with break? We'll come back in about 15 minutes.